contains 2 weeks. First week was in the last week, and now we are speaking about the general trauma. We will finish on Friday, and then we will go ahead with the upper limb trauma course. النهارده معانا 2 very eminent speakers. They are not just eminent in science, ولكنهم eminent في الأخلاق قبل العلم. أستاذنا أستاذ دكتور بروفيسور أسامة فاروق، Professor of Orthopedic Surgery Assiut University وأحد أعمدة الAO في مصر، وأستاذنا أستاذ دكتور هشام العشري Military Academy. خلقا وعلما وأدبا يعني كلهم مثال لنا يحتذى به. فإحنا يعني نتشرف إن يكون موجود معنا عالمين من أعلام جراحة العظام في مصر. النهارده أستاذنا الأستاذ دكتور أسامة فاروق will speak about basic concepts of internal fixation. May you please start, sir?
بسم الله الرحمن الرحيم. First of all, I would like to thank Professor Mohammed Al-Ashhab, the head of Department of Orthopedic Surgery, Benha University. It's a great pleasure and honor to be part of this program, the online trauma course organized by your department and your team. والحقيقة الأستاذ الدكتور محمد الأشهب يعني أثرني بطيب خلقه ودعوته الكريمة والبرنامج الجميل اللي هو بيتبناه هو والتيم بتاعه ويشرف عليه. إن شاء الله يكون من أنفع البرامج في Continuous Medical Education in Egypt for orthopedic surgeons. We will start. I'm going to talk about the basic concepts of internal fixation, and we will come across some points. The effect of a spectrum of stability on fracture healing, and we will go through the evolution of principles, and we will review together the principles of internal fixation and what to apply in each fracture type. And lastly, we will talk about how to improve our techniques of plate fixation in order to get the best outcome in this surgical technique. Before we start to talk about the principles of internal fixation and the stability, we like to talk briefly about the fracture healing. Bones naturally heal by callus formation. Even when left alone, the natural pathway for the bone to heal after fracture is by callus formation. And the natural response to this interfragmentary movement is callus. When left alone, we may get deformity during healing in the form of shortening, angulation, and rotation. What happens usually after trauma? The first insult after trauma is injury. And this is the first initiating mechanism for fracture healing. This injury results in soft tissue damage that should be always kept in mind. There is always soft tissue damage around the fracture, the disruption of blood vessels, and separation of bone fragments. The hematoma forms, and this will initiate the inflammatory phase. It is an inflammatory insult. The trauma to the bone and soft tissue is an inflammatory insult. And this leads to local accumulation of macrophages, neutrophil granulocytes, mesenchymal stem cells, release of cytokines, and delivery of progenitor cells from the periosteum. The coagulation of the hematoma leads to initial stabilization, and the fibrin fibers that will form will stabilize this hematoma. It is the very early stage of callus formation. It is the organized hematoma. The collagen fibers that form will lead to what is called the granulation phase, the soft granulation tissue. This is the very beginning. Then fibrocartilage will form. There is transformation to fibrocartilage. And this fibrocartilage, in the presence of some stability of the fracture, will be transformed to another tissue through enchondral ossification, giving this granulation tissue some hardening. So it will transform from soft granulation tissue to hard granulation tissue. And if the atmosphere is still stable around the fracture zone, woven bone will form, will take place. And now the fracture is united. This is the union that we see in the X-ray, and the patient feels when he gets his broken bone stable again. After forming this woven bone, we come into a later phase of fracture healing, which is the remodeling phase. We should understand this point very well because we will return to it again during our talking about the types of stability. Only after complete stabilization of the bone, there is no any interfragmentary motion, the remodeling phase will start. And the remodeling phase will aim at two main functions. The woven bone will be remodeled into lamellar bone by what's called the cutter cones. This diagram shows the cutter cone. The cutter cone is cutter head formed of osteoclasts that makes the tunnel through the woven bone to lay down the lamellar bone, followed by the osteoblasts that lay down the lamellar bone. This is what's called remodeling phase, only after cessation of the interfragmentary motion. Another function of remodeling is to regain the normal shape of the bone, to remodel the medullary canal and remove the external bony callus and form the cortices again. This is a long process that will take more time and depends on the stresses applied to the bone. It is the influence of destructive and compressive strains according to Wolff's law. Here, I would like to talk briefly about the strain. What is the strain? And why should we talk about strain in this part of the presentation? The strain is the amount of deformation or motion that occurs at a fracture gap as a result of load applied to the fixation construct. يبقى عندنا كسر، احنا عاملين stability of the fracture, but there is still some motion inside the fracture zone. This amount of motion or deformation is called the strain. How can we calculate the strain? It is calculated by comparing the original length of the fracture gap to the size of the gap under stress. Simply, the amount of deformation over the length of the gap. Let us have an example. If we have a gap of 5 millimeter and the fracture is deformed under stress by 2 millimeter, so the amount of strain will be 2/5. If we have a gap of 20 millimeter, so we will have the amount of strain 2/20. So the larger the gap in the presence of the same load applied, the less strain we will have. The smaller the gap with the same amount of stress applied, the higher the strain we will have. Look at the stiffening of the callus during the different stages. In the soft granulation, you can see the deformation of the callus. So it is liable to disruption. When the callus gets more and more stiff during hardening of the granulation, the deformation will be less. So the chance of cutting or disrupting this newly formed granulation becomes less. When it is hard bone by enchondral ossification, it is more and more stiff, and the risk of getting disruption of the callus is less. We have this article talking about the initial phase of fracture healing is specifically sensitive to mechanical conditions. Why? Because in the early phase, movement may cause excessive tissue deformation that may risk the repair and the continuation of callus formation, and this newly formed tissue may disrupt or may be delayed. So we may get either delayed healing or non-union. This means we should have an atmosphere of adequate stability in order to maintain the ongoing process of fracture healing. Now we will talk about the stability. What is the stability? It is the ability of the fracture to withstand the functional load. It is the ability of the fracture to continue healing under this functional load. It is some degree of lack of motion between the fracture fragments. And as we all know, we have two types of stability. The absolute stability means there is no micromotion at the fracture site under normal physiological loads. And the relative stability indicates that there is some motion between fracture fragments. What about rigidity? It is another term. It is the ability of the implant to withstand deformation. If we look to the spectrum of stability from 0 to absolute, At the zero side, we will get instability. And this instability will disrupt our granulation tissue, our newly formed callus, and we will get non-union. If we look to the other arm of the spectrum of stability, we will have absolute stability, where there is direct bone healing. There is also no callus, but we will get healing by direct osteonal migration, by remodeling. In between, we have relative stability by splinting the fracture, and we will get callus formation. This is what's called the spectrum of stability. So how can we achieve the absolute stability where there is no micromotion at the fracture site under physiological loads? This requires anatomical reduction of the fracture and requires bone contact between the two ends of the fracture. So it requires open reduction and putting the fracture under interfragmentary compression. What is the effect of absolute stability? We put the fracture under conditions similar to what we achieved in our process of callus formation. You remember, we said the remodeling stage, it starts only after complete stabilization of the newly formed callus, where there is no any more motion between the fracture fragments. When you apply these conditions, putting the fracture under absolute stability, callus will not form, but we will get what's called direct bone healing. It is a primary bone healing. It is an internal remodeling of the bone. It is direct osteonal migration by the cutter head. The osteoclast will open the way, the osteoblast will lay down the new bone in the form of lamellar bone. So these cutter cones will do the job, the internal remodeling to heal the fracture under absolute stability. And you will get healing of the bone like this without any callus formation. We have two types in this aspect of bone healing. You have what's called contact healing, when there is no gap between the fracture fragments. This will absolutely facilitate the bridging of the cutter cone across the fracture line, as we can see here. We don't have any problem. There is no gap. And we have what is called gap healing. And gap here is very relative. It is not that gap we imagine when we hear gap healing. It is only very, very minimal gap. How can the physiology of the bone overcome this gap under the conditions of absolute stability? This is a very tricky point, because the influence of the size of the gap will determine the success of fracture healing or the failure of fracture healing. This means if I have a small gap, very small gap, bone healing will continue and will be successful. If you have a gap less than 0.5 millimeter, capillary ingrowth will take place and the lamellar bone will form around these capillary vessels, then the osteonal penetration by the cutter cones will take place, and internal remodeling will take place, and the fracture will unite. If the gap is larger than 0.5 millimeter, it will heal only by callus formation. This point again will determine the success of or failure of our surgical technique if we put our fracture under absolute stability. If you have a gap, please leave the holes of the plate opposite the gap to allow some motion to heal the fracture. Leave 2 or 3 holes opposite the fracture area. This will give a chance for healing. We will come again for this point later. So the requirements of achieving absolute stability: direct bone contact, no gap, anatomical reduction, no motion between fragments by interfragmentary compression. How can we achieve interfragmentary compression? Leg screw is the best tool for interfragmentary compression, and plate fixation, if we direct its function to act as a compression device. We have the compression plate that will function through axial compression mechanism. We have the plate as a neutralization plate added to leg screws. We have what is called the tension band principle, or the dynamic compression, using the plate as a tension band plate. And lastly, we have the buttress plate across metaphyseal fracture. All these will function as compression plates. The leg screw, we all know, it is a technique of insertion, and it results in absolute stability. The best compression will be achieved if you have your leg screw perpendicular to the fracture plane. You have a gliding hole and thread hole is an easy mechanism, and you will get compression up to 2,500 or 3,000 Newton of force. Just one point, it looks a simple point, but it is worth to mention: the countersink in cortical bone. Why should we use the countersink in cortical bone? Because the maximum stress is between the screw head and the bone cortex. The countersink will help to maximize the contact between the screw and bone and to minimize the stress at the interface. So you will not get fissuring of the cortex while you are tightening the screw. These are examples of leg screw fixation in articular fractures. You all know that the examples in articular fractures, in fracture neck of femur. What about the axial compression? How can we use the compression plate with axial compression? We all know the eccentric screw mechanism. You put the screw eccentric in the dynamic compression plate, the oval hole, so you will get compression of the fracture site. Of course, all these methods are done in simple fractures, like this fracture. We have another device, the articulated tension device, as a compression device. We have also the pull technique. If you insert a screw away from the plate and use the self-centering clamp to pull the plate, then you will have compression across the fracture site. And this is a study, mechanical study published in the Journal of Injury about optimizing compression, comparing the three mechanisms, the eccentric screw versus the articulated tension device and the pull technique. You can see the best one is the articulated tension device in exerting compression, followed by the pull technique, and lastly, the eccentric screw. So if you need to compress the fracture in such situations, you need to have more compression, like doing osteotomies, like cases of non-union, like cases of subtrochanteric fracture. Don't hesitate to use the articulated tension device. So you can have this nicely post-operative X-ray of axial compression. You cannot see the fracture site. The second type of plate, the neutralization plate, you use a leg screw or multiple leg screws and put the plate to neutralize the forces around these leg screws, the axial and torsional forces. This is the neutralization plate. What about the dynamic compression when we use the plate as a tension band plate? You can use it in the situation of bones having a tension surface and compression surface, like the femur. The second prerequisite is intact medial cortex. You cannot use it with disrupted compression site. So if you put the plate on the lateral side with pre-bending and exerting compression on the fracture site, this plate will convert the tensile forces on the femur by its anatomical shape, tensile surface, compression surface. You put the plate on the tensile surface, it will convert the forces, the tensile forces, into compression forces on the medial side. So it is some sort of dynamic compression. It is a tension band plate. The last one is the buttress plate. It resists shear forces across metaphyseal fractures. And the famous example is the use of buttress plates in tibial plateau fractures. So to summarize the indications of absolute stability, fractures requiring anatomical reduction, articular fractures, simple fractures with bone contact, like the forearm fractures here, also can be done in diaphyseal and metaphyseal simple fractures, especially in upper limb fractures. What are the violation of principles of absolute stability? When you use these techniques in multifragmentary fractures, then you will get cases of delayed union, non-union infection. If we don't respect the vascularity of the bone, the soft tissue, the periosteal stripping, too much metal, so we will get these complications: implant failure, delayed healing, non-union, wound complications, infection, breakdown of the soft tissue. In the past, the surgeons were fascinated by this type of bone healing, the direct bone healing under absolute stability. So they used to use it in all types of fractures, even in multifragmentary fractures. And we got these complications. And then the principles changed according to what they got from the documentation of cases and the outcome. The principles were anatomical reduction of the fracture, then they become functional reduction. Rigid fixation becomes stable fixation, and preservation of the blood supply is always needed for the fracture to heal. And the aim is to mobilize our patients as early as possible. So a crucial balance between stability and biology is needed in order to have our fracture healed. In order to have healing of our fracture, we should have this balance. And the evolution of principles from the 90s up to now is about how to improve the biology to change the surgical technique toward more biological approach. And the functional reduction will prevent devitalization of small bone fragments. Using indirect reduction techniques to minimize the soft tissue damage at the fracture zone. Applying the principles of relative stability to enhance bone union by callus formation, the natural bone healing. And there is many development and changes to improve the implant design in order to avoid the drawbacks of the standard or the classic plates, in order to improve the perosteal blood flow underneath the plates and to manage the drawbacks of the conventional DCP. What about the functional reduction? Functional reduction means to regain the normal mechanical axis of the limb, to restore length, axis, and rotation. So we will get union without shortening, without angulation, and without rotational deformity. But anatomical reduction of every fracture fragment of the shaft is not needed. So the relative stability becomes a concept in the early 90s up till now, from 1989 exactly till now. This is a change in the mindset of surgeons. You accept some motion, but below the limits of tolerance of healing bone tissue. And you are now happy to see callus formation in the fracture zone. In the past, callus formation means failure of the implant because the fracture is not under absolute stability. But now you feel happy to have callus formation. And relative stability means you splint the fracture, either intramedullary or extramedullary, in order to have this atmosphere of keeping the natural process to take place, and at the same time applying the functional reduction. These principles are applied to multifragmentary fractures, especially multifragmentary fractures that cannot be reduced one fragment to the other, because it will devitalize the bone fragments. All what we need is to have the anatomical alignment. And we use the indirect reduction techniques in order to get the functional reduction. Why multifragmentary fractures? Again, they tolerate more motion between the fracture fragments. Why they tolerate more motion? Because we have this fracture zone, the big fracture zone, and the deformation, when we calculate the strain, the deformation occurring here is minimal, because we will have the equation, the deformation over the fracture length. And you have many fracture planes that will reduce this tissue strain and the tissue deformation. And you will get healing of the fracture if this interfragmentary strain is below the critical strain for tissue repair. Now we can understand the issue of strain. Ultimately, these multifragmentary fractures will heal by callus formation, the natural bone. And the clinical indications for relative stability is clear. It is non-articular multifragmentary fractures, whether diaphyseal or metaphyseal. You can refer to this article if you like to have more information about this. How can we achieve relative stability? What are the methods? All methods are splinting techniques of the fracture. Traction, for example, plaster cast, external fixation, intramedullary nailing, bridging plate. All these techniques aim to give some stability adequate enough to let the newly formed callus to proceed to hardening and to form the hard callus, to minimize the strain at the fracture zone, not to interfere with the blood supply of bone fragments. Here we have an example where we can apply the principles. We have this distal multifragmentary femoral fracture with articular involvement. We have multifragmentary supracondylar intercondylar fracture of the femur. We apply the principles of absolute stability for the articular block. We need anatomical reduction and absolute stability by leg screws for the articular surface. But we need relative stability for the metaphyseal fragments. What about the indirect reduction techniques needed for relative stability and to use the methods of achieving relative stability, whether intramedullary nails or plates or external fixator? These indirect reduction techniques depends on traction. You do traction, you reduce the fracture, you get axial alignment, you correct shortening, and then you have your skills to prevent malrotation and to judge that the fracture is now aligned and you get function reduction. You may get this needed traction manually by having an assistant who can do traction the whole time of the surgery, or you can use some tools that will help you and save an assistant, like the fracture table, the femoral distractor, the external fixator as a temporary reduction tool intraoperatively to keep the fracture in the reduced position, and the push-pull technique in order to reduce the fracture like we see here in the diagram on the left side below. We have also other tools to achieve indirect reduction rather than the traction. For example, in supracondylar fracture of the humerus, in order to neutralize the pull of the two heads of gastrocnemius, you can put bolster or towels underneath the knee to flex the knee. This will neutralize the forces and help indirect reduction. You can use the implant as a reduction tool, as we can see here in this distal tibial fracture. The plate was used as a reduction tool, but this requires proper contouring of the plate. We can use the polar screws in order to correct any axial malalignment during intramedullary nailing. But the principles are still going towards the biological approach. And we are in the era of minimal invasive surgery in all specialties, not only in fracture management. Minimal invasive doesn't mean to have small incisions, but it means keeping the biology of the bone and minimizing the soft tissue trauma. I would like to comment on this minimal invasive plating techniques in two aspects. First one, when we use it in articular fractures with metaphyseal extension, we should have a soft tissue window opposite the articular fracture big enough to expose the articular block in order to achieve anatomical reduction of the articular surface and to have good orientation. The second one, on the shaft side, we should have a soft tissue window that will enable us to centralize the plate on the bone. Otherwise, we will have troubles. We will discuss later. We have now what is called small footprints instruments in order to help you to achieve reduction using minimal invasive techniques, like minimal invasive plating, closed nailing. These tricks, as the joystick technique, when you do intramedullary nailing, you can use such a trick. This will help you to reduce the time needed for reduction and minimize the exposure to irradiation. Again, we have the pointed reduction clamp that can be inserted percutaneously, as we can see here in the picture on the left side below. During plating, a minimal invasive plating of the distal tibia, it helps to keep the reduction during the fixation of the plate. It can be used as well in intramedullary nailing of the tibia, because the tibia is subcutaneous. You can insert this pointed reduction clamp to keep an oblique fracture during introduction of the nail or the plate. Again, you can use some tools like the bone hook and the ball pointed pusher to help in reducing subtrochanteric fractures, for example, during intramedullary nailing, using just small incisions to introduce your instruments. Again, you have the collinear reduction forceps. It can be introduced through a small window to pull the shaft to the plate in minimal invasive plating techniques. When you put a plate through small incisions, a MIPO technique or minimal plating osteothesis technique, the conventional plates will not help. You have a risk when you use these conventional plates, the ordinary DCP, because in minimally invasive techniques, you cannot guarantee that the plate is 100% adapted to the bone. It may be elevated off the bone by the soft tissue, and this will lead to reduction of the stability of the plate because there is no friction between the plate and the bone. And we will talk about this. Another limitation of the conventional plates, they fail in osteoporotic bone. And lastly, they affect the periosteal vascularity and cause bone necrosis under the plate, as we can see here in these diagrams. if we know the biomechanics of conventional plates, we will know why they cannot be safely used in minimal invasive plating techniques. These plates depend on friction. They get stability by friction to the bone. So the plate should be in contact to the bone, not to have any space between the plate to the bone. So the plate bone interface here is stable by the screws. And we have forces applied to the plate bone interface. Axially, we have the axial load, we have bending load, and we have torsion. These axial stresses, either tension or compression, will cause shear stress at the plate bone interface. And if you have a gap between the plate and the bone, the plate will fail, either due to bending of the heads of the screws or gradual bone resorption by repeated motion of the plate on the screws, and these screws will get pulled out gradually. To avoid these drawbacks of the conventional plates, the era of locked plates came into practice, and they act as internal fixator. So you have the screws locked inside the plate. You have a fixed construct between the screws and the plates. You don't need to have your plate 100% adapted to the bone. It acts as an internal fixator. And they act actually as a single beam construct. And they resist the shear forces across the plate bone interface. And in order to fail these plates, you have to shear all the screws from the bone. What are the advantages of these locked plates? They give angular stability. Accurate plate contouring is not required if you use only locked screws. You don't need to have full bone contact, and this will keep the perosteal blood supply underneath, and you have less screw loosening, especially in osteopenic bones. What are the clinical indications? They are indicated especially in short segment fixation, metaphyseal comminution, or short metaphyseal fragment, like the case we have here. I think there is no any other tool can help except locked plates, locked anatomical plates. Second indication, osteoporosis. Conventional plates will not help. Third, periprosthetic fractures, like we have here. So you can have locked screws in osteoporotic bone around prosthesis. They will help. This is short segment fixation again. And lastly, in minimal invasive plating techniques. And we explained why. How can we optimize our plate fixation? We have some factors that we should consider when we practice the art of plate fixation. The plate length, the number and length of screws, the positioning of screws, and the plate distance from the bone. We are talking now about the locked plates, okay? How to optimize the locked plate fixation. We use these plates as bridging tool to splint the fracture. It is a bridge plate. And if we have a fracture zone, we have to measure this fracture zone and to use a plate length at least 2 to 3 times the length of the comminuted zone. So if we have a fracture zone opposite 4 holes of the plate, so you should have at least 12 holes plate. The plate length is very important because the stress reduction in the plate relates to the plate length. The increased plate length will reduce the stresses over the plate. It is more important than the working length. Yes, working length is important because it has an important effect on the construct stability. When you have a comminuted fracture like this, you should insert the nearest screws to the fracture zone in order not to have a longer unneeded working length of the plate. So you need a long plate. The longer the plate, the better the fixation because it reduces the stresses. You have long working length opposite the fracture zone. You don't put screws inside the fracture zone, but you put the nearest screws proximal and distal to the fracture zone in the intact bone. This is regarding the fracture length. The number of screws. The plate screw density should be less than 0.5. This means you leave half of the holes empty and put screws in half of the holes of the plate. You need more than 4 cortices per fragment. So it is preferred to have at least 3 locked screws. And this will differ when you are getting fixation in short segment, in periarticular fractures. You need more screws. More than 3 screws will not increase the axial stiffness of the plate. More than 3 locked screws, I mean, will not increase the axial stiffness of the plate. They may increase the torsional stiffness if you have 4 screws. But 3 locked screws in each fragment, especially in good quality bone, are good for fixation. Avoid stress concentration. In comminuted fractures, you leave, as we said, the whole fracture zone without screws. And you put your screws in the nearest intact cortical area, proximal and distal. This will lead to a flexible construct, not a so rigid construct. And the fracture zone will have some micromotion that will help healing as well. However, in simple fractures, if you put the screws like this in locked plates, the stress concentration is higher on the junction of the plate opposite the fracture line. And if you have a small gap, you will not allow gap healing because you don't give any flexibility to the construct to allow some movement in the fracture area to help callus formation. So it is recommended to leave at least 2 holes opposite the simple fracture in order to give some flexibility of the construct and to prevent stress concentration and breakage of the plate. This is an example to understand it. Here, although it is a simple fracture, it was a revision after failed fixation. 2 holes were left, or 3 holes were left opposite the fracture zone. This will give some flexibility, and healing took place by callus formation, although it was a simple fracture. To use monocortical screws or bicortical screws, always use bicortical screws. The monocortical screws, they will not offer sufficient working length. The purchase of monocortical screws is very little, and especially in osteoporotic bone, you will not get any stability. Always use bicortical screws to have a sufficient working length of the screw. They are 3 times more stable than the mono-locked and 3 times more than the conventional bicortical, more stable. Take into consideration to center the plate on the bone. Otherwise, if you have the plate eccentric on the shaft, you will get, again, very little purchase of the cortex. And in locked plates, you cannot redirect your screw to have the whole diameter of the bone. This is another important point. So we said in minimal invasive plating techniques, have a small window enough to allow you to center the bone, to avoid eccentric positioning of the screws and less working length of the screw. The last point, the distance from the bone. Is it important? Yes. When you have a distance between the plate and the bone up to 2 millimeters, it is still accepted. But if you increase the distance, the torsional and axial stiffness will decrease significantly. So it is not recommended to leave the plate, although it is an internal fixator, to leave it away from the shaft. Okay? Keep it as near as possible. If you like to have more information about how locking plates fail, I would like to recommend this article. What are the developments in locked plates? The variable angle locking screws. You all know it is useful in periarticular fractures, not only in periarticular fractures, but also in peri-implant and periprosthetic fractures, like this case with peri-implant fracture around intramedullary nailing. And if you have polyaxial locking screw, you can have bicortical fixation using this technique. Again, one of the developments is the locking attachment plate. It is very useful in periprosthetic fractures, where you can attach this small plate to the locked plate and have screws around the implant inside the medulla. Before I end my talk, I would like to emphasize the significance of stability, not only on bone healing, but also in fracture-related infection. If you have an open fracture, if you have an infected fracture, never to leave the fracture without stability. Instability and continuous movement at the fracture site will lead to ongoing soft tissue trauma, inflammation, release of inflammatory mediators, local immune suppression, hematoma formation, interrupted neovascularity. This will compromise penetration of systemic antimicrobials and as well the host immune response, the white blood cells. And this continuous movement will lead as well to osteolysis of the bone, bone resorption, implant loosening. These all are supportive environment for bacteria. They invite bacteria and they invite proliferation. And this will increase the osteolysis and we will get into vicious circle of instability and infection. In these cases, the working horse is the external fixator and the ring fixators to offer the needed stability with eradication of infection. The take-home messages of this talk: the cascade of events in fracture healing, acute fracture, hematoma formation, microvascular ingrowth of granulation tissue, cell differentiation to bone. Then we have our intervention, and the type of healing will depend on the type of fracture, type of reduction applied by us, the stability and the implant chosen for the patient. If we have a simple fracture and applied anatomical reduction under absolute stability, direct bone healing will be the net outcome. If we have a complex fracture with anatomical alignment, functional reduction, relative stability applied, callus formation, the natural bone healing will take place. If we compare absolute stability to relative stability, in absolute stability, we have healing with direct bone healing. This means internal remodeling of the bone. It can be achieved only if we have anatomical direct reduction. It is indicated in articular fractures, simple shaft fracture, especially of the upper extremity. There is no movement possible at the fracture site, no gap at the fracture site. It can be achieved by leg screw interfragmentary compression, a compression plate, and tension band wiring or tension band mechanism. The relative stability, where healing takes place by callus formation, we need functional indirect reduction. It is indicated in shaft fracture of the lower extremity, metaphyseal or diaphyseal multifragmentary fractures with either nail or plate. We have some micromotion at the fracture site, they tolerate gap. Splinting or bridging is the principle, either by intramedullary nail, bridge plate, or external fixator. The spectrum of stability range from 0, where instability will lead to non-union and no callus will form, through relative stability, where callus forms, and this can be achieved by splinting of the fracture using external fixator, intramedullary nail, bridge plate. And lastly, on the other side of the spectrum, the absolute stability, where no callus forms, but healing will take place by internal remodeling under compression using leg screws or compression plates. Thank you very much for your attention.
Thank you so much, Professor Osama Farouk. Sir, I don't know what to say. Marvelous presentation summarizing all the aspects about basic concepts of internal fixation. Thank you so much, sir.
I thank you very much for giving me this opportunity to be part of your online trauma course.
هو أستاذنا دكتور أسامة بيه، هو كمية الحضور تدل على حاجتين، على ثقل المحاضرة وعظم المحاضر.
يا فندم العفو.
الله يخلي سيادتك يا فندم.
وده من ذوق حضرتك واخلاق حضرتك اللي دايما حضرتك بتاثيرنا بيها.
ربنا يكرم سيادتك يا استاذنا. لو حضرتك سمحت لي، هو we have lots of questions. المحاضرة بصراحة يعني أنا مش هقول رائعة، هي أكثر من رائعة يا فندم.
العفو يا فندم، العفو.
هنبدأ بالفيرست كويستشن يا فندم. معانا أخونا بروفيسور محمد عبد العال. He has lots of questions. First question to Professor Osama Farouk. What controlled the sequence of bone healing? Why started by granulation, then fibrocartilage, then endochondral?
This is the natural process of bone healing. Callus formation is a unique type of healing in the tissues inside the body. Healing is by a process called reconstitution. This is the English term, reconstitution. It is not like the healing of the liver. If you have a liver tear, it will heal primary healing. The skin, you have healing by primary intention or secondary intention by scar, healing by scar in many soft tissues of the body, or primary healing by the same cells. But in bones, you have healing by callus formation. It is a reconstitution, staged healing. ولذلك حتى ربنا سبحانه وتعالى لما ضرب مثل على إعادة الخلق ضربوا بالعظام، لأنها مثال لإعادة تخليق الأنسجة، مثال للريكونستيتيوشن اوف تيشوز. وضرب لنا مثلا وناسي خلقه قال من يحيي العظام وهي رميم قل يحييها الذي أنشأها أول مرة وهو بكل خلق عليم. فالستيجز دي اللي هي ماشية من هيماتوما، الهيماتوما والinflammatory phase will recruit the inflammatory cells, will recruit the progenitor cells coming from the periosteum. We have blood supply from the periosteum that will take place due to interruption of the medullary blood supply. Then we have the recruited cells to lay down bone. The stem cells and the progenitor cells will be transformed to lay down bone, and we have this external callus to give the stability till the medullary blood supply will be regained again, revascularized again. So it is a process depending on the ongoing stability during fracture healing. If you have a strain that will disrupt this tissue, it will not transform from fibrous to fibrocartilage to woven bone.
Yes. Another question, sir, from Dr. Muhammad Ali. What's meaning by cutting cones? هو طبعا حضرتك شرحتها باستفاضة يعني، بس واضح ان دكتور محمد يعني ما حضرهاش من الأول.
الcutting cone, this is the unit, the bone remodeling unit. The bone remodeling unit is formed by central vessel, and you have cutter head osteoclasts followed by the osteoclasts. The osteoclasts will open the way. They usually resorb the bone. So they open the way for the natural process of remodeling inside the body. And then the osteoblast will lay down lamellar bone. It will take place in case of fracture healing as a natural process, only after having the woven bone stabilizing the bone. And there is no any movement at the fracture site. At this stage, remodeling will take place in order to achieve two goals. The first one is to transform the woven bone to lamellar bone, then the normal bone, and to regain the shape of the bone. We all follow up our patients, and you can see how the newly formed callus, the big callus, will be remodeled to have the normal shape of the bone later on. And in children, you have the very high remodeling power. So you can see this process taking place very quickly than the adults. It is a good example of remodeling.
Yes. Another question, sir, please. What about the controversial rule of intrafragmentary screw between increased compression and interference with blood supply to the fractured fragments?
If you mean in order to have an interfragmentary compression, you will devitalize the bone and you will strip the periosteum, then you have the compromise between the mechanical stability and the biology. Be on the biology side. But if you can put your leg screw without soft tissue stripping, without devitalizing the bone, with just small footprint instruments like pointed reduction clamp, and then you put your leg screw without direct manipulation of the bone by big clamps, then you can have it if possible.
Yes, sir, please, is there a difference between pre-stressing and pre-bending of a plate?
Pre-bending of the plate is needed in transverse fractures to compress the medial side. You put the plate on the lateral side, for example, of the femur. You have this side, and the other side, if you don't pre-bend the plate, it will not be under compression. So before applying the axial compression by eccentric screws or articulated tension device, you need just to do some pre-bending in simple fractures with intact medial cortex. So you will compress the medial side. It will be kept under compression when you tighten your screws. So you achieve axial compression without opening of the medial cortex.
Yes, another question, please, sir, from Dr. Wael. Why is articular tension device superior than the other techniques in achieving stability?
The articulated tension device, لو احنا فاكرينها، هي ليها ناحيتين. It has two ends. One will be under the plate surface, under the last hole of the plate opposite the side, we will do the compression. And it has an extension where you put your screw inside it. So it is stabilized to the bone by one screw and the other foot of the articulated tension device under the plate. And then you have green, yellow, red zones on the articulated tension device. You use the wrench to tighten this tension device. And you don't need to exert much tightening, otherwise your screws proximally may fail. You just put the fracture under compression and you will see by your eyes, the fracture is compressed. You feel it compressed enough and the plate is tensioned by this tension device, then you put your plate on the distal side where the articulated tension device attached. You will have a very stable construct if you use this technique. It is very useful in osteotomies, in cases of non-union, in subtrochanteric transverse fractures, especially.
لو حضرتك سمحت لنا دكتور اسامه ناخد more questions ولا نكتفي يا فندم؟
حسب راحه حضرتك.
انا مش عايز اتعب حضرتك بصراحه يا فندم، بس هي المحاضره يعني اكثر من رائعه بصراحه.
يا فندم العفو.
We have 3 more questions. First question, if we use conventional screws in the combi hole of locked plate, does this will change the concept of screw density or the working length of the plate?
السؤال ده سؤال جميل علشان هيخلينا نتكلم انه locked plate with combi hole is a tool, and you use the plate as a tool to have the function you like to have. انا ممكن اللوكد بليت اشغلها ناحيه، اخلي المسامير كلها ستاندرد for example, the side of the shaft and the side of the metaphysis toward the articular fracture in anatomical plates, all locked because it is short segment fixation and the bone in the metaphysis is weak. So I will put locked screws on this side, standard screws on the other side. If you plan to put standard screws, they should be the first screws to be inserted, not to put the locked screws and then to put a standard screw. Why? Because the locked screw will act as internal fixator and the plate is away from the bone. It is not well fitted to the bone. And if you put your standard screw after fixing the plate with the locked screw, you will stress the screws inserted because you will force the plate towards the bone. And the locked screws inserted before this will be stressed. So please put the standard screws first and then the locked screws. You distribute the screws according to the fracture pattern, whether standard or locked. It doesn't matter.
Another question, sir, from Dr. George Romani. In oblique fractures, when we use DCP, what screws we should put first, the eccentric or the central one?
In oblique fracture, you should see the fracture plane and imagine where the fracture will slide. Where the fracture will slide will determine the side eccentric screw. It will force the fracture under the plate to compress it. It will not glide. So this depends on the fracture configuration. Okay, you put your central screw first and then the eccentric one, but please plan it. Otherwise, you will get gliding of the fracture. It will slide and the fixation will not be compressed.
Yes, please. The last question, sir. What are the criteria and indications to use the MIPO?
Okay. In periarticular multifragmentary fractures, this is the very clear indication. You put the plate because you will not be able to put a nail. So you will open a window adequate enough to expose the articular surface and reduce it and put it under absolute stability, then put your plate. Here you will push the plate submuscular and retrieve the plate on the shaft side, crossing or bridging the fracture zone, which will be untouched with intact soft tissue, intact periosteum. Only the soft tissue is stripped by the trauma, not by the surgeon. This is the very clear indication of MIPO techniques. In the shaft, you have the option of intramedullary nail, which will be superior to the plate as it is load sharing device.
Thank you so much, our beloved Professor Osama Farouk. هو أنا حضرتك استمتعت